sweat more during peacetime, so you bleed less during war. What does that really mean? How does that relate to anatomy and therapy and treatment and patients, helping your patients get better? Today, I think we're going to get into it through the ribs or your neck pain or your weird elbow pain. Is your neck pain coming from your neck? Is your elbow pain coming from your elbow? Is your shoulder pain coming from your shoulder? We're going to figure this out together today. But we're also going to sweat a little bit during peacetime so that when war comes around, we'll bleed less. That's what they say, right? But welcome to the Anatomy of Therapy. I'm Dr. John Cybulski. Today here with Bobby Riley in quickly darkening Iceland. The sun just starts to go down there so fast. But you had some interesting cases, and I think you do a really good job. And I like the way that you look at rib or back pain, neck pain, elbow pain. You've got some good kind of general ways to look at it and specific ways to go kind of weed out what the problem really is. And I want to kind of get into that. Like, so how do you find rib problems? Because patients are like, my ribs popped out. How do we start to discern and pick these things apart?
Well, first, I think the patient that comes and says my ribs popped out has already been to a practitioner before.
For sure.
So if you get that
Absolutely.
person, they were with somebody who used that, that vernacular to kind of explain their injury.
Mm-hmm.
And honestly, I think that made sense to me a long time ago, because it just seemed like a innocuous way to just quickly explain something to a patient. Of course, it's not truly popped out, because they would be in the hospital, especially if it was on the spinal side of the dislocation.
You wouldn't be speaking that fluidly. It'd be a knife in your,
Yeah, I mean, I've never even heard of those really dislocating on the backside.
Right.
But that's just, it seems like a very elementary way to just explain the pain away real quickly to a client or a patient, right?
Sure.
But we all know that they don't dislocate. And honestly, I mean, you could use, actually, I'm more okay with the word subluxate in this way, because you could just say, well, it's not sitting in the right position, or it's not freely moving, but I personally don't even use that word for this scenario. I don't think it's even necessary. I think these are quite explainable just by discussing what's actually going on. And patients get it. So I don't think we even have to dumb it down to the point of a rib popped out.
Let me stop you real quick. So like you said,
Sure.
I agree with you actually going on. Ribs aren't popping out of the spine. And that actually being more helpful, because I don't see the use in telling someone that their rib is popped out, and you're going to push it back in. There's not a great way to confirm it. We know this, palpation studies or even imaging stuff, it is not consistent in terms of being like, oh, yep, there's T3, it's out again. It's just not a consistent way to practice. And I do know, I've had friends that have popped people's backs and then they feel a bit better. So that is a reality as well. However,
Sure. I mean, but it's just can be a rational explanation for why that adjustment actually helped.
Right.
So let's say you adjust a rib head or the costovertebral junction or something.
Yeah.
Well, if you have these muscles and knots that are kind of maybe binding that rib down, it's kind of, it's not able to expand or move, or whatever, bucket handle or caliper motion or any of these things that a rib should be able to do. And you put a thrust through there, we know, just the same way that an adjustment can work through GTOs and other mechanoreceptors and proprioceptors, that can create a relaxation of the tissue around it. And it can also just mobilize the rib slightly, which may be in some instances enough to just create some movement in there, if the pain or the irritation is coming from a lack of movement, because it's not free enough. And and in a case where it's too mobile or something like that, maybe it's not the best option. But I think we'll get into the scenarios of what this means, I think, and what maybe is going on with the rib. So I think we'll get into that a little bit later, right?
Sure.
But I just, maybe to give you some more clinical, what do you say, gems in this regard, is I rib area, we'll just call it, we won't say rib pain because we don't know if it's the rib particularly, but we say that inside the shoulder blade, under the shoulder blade, T-spine, T3, 4, 5, 6, 7, something like that. When people come in with issues with that, in my experience, I'm thinking of that problem on anything upper. If they come in with headaches, if they come in with neck stuff, if they come in with an achy shoulder that doesn't seem to be specific, like with glenohumeral movement, if they have some kind of non-specific radiating or irritating pain down the arm or in the elbow,
As
I
like a
rule that out right
differential.
away.
As like a differential.
Yeah, I mean, it goes immediately on the top of my list.
Yeah.
It's up there with, of course, you got to rule out. It's not as serious in nature as something like a disc herniation in the neck or other, TOS or stuff like that. But it's still, it's so easy to rule in and out that it goes to the top of my list, and it's so common
Yeah.
that, I mean, for every cervical disc I see, I have 10 of these. 10 of them. I mean, they're just so common. And I think it's probably the most missed thing out there. And I think I've focused on these actually since I graduated. So if there's one area where I feel like I just somehow, even without tons of evidence to back up everything I do, I think as I've focused on it, it's just like a coach who just, he didn't read Verkhoshansky. He's just been coaching his whole life, and he just kind of knows what to look for when the person's running. Or I feel like, you say, yeah, there's not this good inner rate of reliability in palpation, for example, but amongst yourself, you may have some good reliability amongst yourself. So I mean, in the sense that I typically can say, this spot hurts, isn't it? And they go, how did you know? So that means, of course, that that there is I have reproducibility in this regard. So what I want to say is, while John is running out of the room and back into the room, I basically want to say that, anytime you have somebody who comes in with neck, shoulder, head, mid-back pain, this is an area that I want you to think about, is this rib area.
Yeah. So, okay. I think I want to go quickly to the way that doctors think about ribs and the way that you're thinking about how ribs are connected to these disparate areas. Okay. Because I agree that there is that connection. I think some people might think that there's a little bit of a leap here. Okay. We're chiropractors, we're physical therapists. We know that everything's connected. But sometimes that line of connection isn't so obvious as it is to you. I think the best way to get there might be, ribs don't go in and out. What do ribs do? Like, I know you were talking about before, we were kind of talking about this episode, and Bobby was talking about the muscles that are attached to ribs. And there's a lot, basically. But so ribs don't go in and out. Let's say there's a minor subluxation or something like that, right? We're not really dealing with that. What if they don't just go in and out? What are the capabilities? Like, what are the capacities or the attributes of ribs?
Yeah, well, it's funny that, I mean, it just seems like everything is about the muscle and the joints, but not the ribs. Like, not these 24 ribs that seem to be wedged in there and highly dynamic and highly needed to coordinate movement, coordinate respiration, coordinate anything, reaching and bending, and anything involves those guys being okay. But I mean, when I was in school, I was not taught rib. I mean, I was maybe taught there's caliper motion, there's there's a bucket handle motion, and there's pump handle motion, and there might have been a 20-minute segment on them. Otherwise, it was anatomy. So what are the protuberances and what are these things called? But that's it. And then when I had manual therapy class, they showed me how to work on knots that form inside the shoulder blade. And I remember the moment I heard that thinking, why do the knots form in the first place? I don't get knots just randomly forming in my forearm. Like that doesn't happen. I would have to pull a hamstring muscle or something. And then, it's kind of recovering. And then you got this little knot where you pulled it or something like that, or a crazy cramp that you got mid soccer game. And then you got this little knot in your calf that's temporary, right? but not these shoulder blades seems like almost, 90% of humans, you can go poke around on them and you can find these knots. And what I mean by knot, they taught me, okay, you can do this, you can do, what is it? The compression where you starve it of
Yeah.
oxygen, ischemic compression, right?
Right.
Oh, they taught me Swedish massage techniques, all these things. And, and,
There's a
and to me,
direction of the, yeah.
yeah, what effleurage and,
Mm-hmm.
but to me, the muscle was just the reaction to the problem. It was
Mm-hmm.
not the cause of anything. So not in these rib scenarios. So I don't know if that kind of was on topic, but
Well, no, I do think, well, I was talking about this with a former guest on the show last night, actually, Dr. Offenberger, about what is the cause of the problem and what do people think primarily is the cause of the problem. And it is very trendy today, and it does answer a lot of questions that the soft tissue is the problem, which is why we have foam rollers and Theraguns and all sorts of soft tissue treatments, because to a large degree, oftentimes the soft tissue is a problem. And if you can make that soft tissue appreciably better, it's filled with sensory stuff and patients feel that you're doing a lot for them. And sometimes you actually do. Specifically in a very deconditioned person where the soft tissue is deconditioned, you put some manual therapy effects into it, whatever your favorite might be, and patients definitely feel something. They may feel something that they haven't felt before. So soft tissue problems can fix a lot of stuff until they don't. You know what? So the soft tissue, I believe, like what you're talking about with the muscle as well, is a reaction to something. So if you do clear out the soft tissue, God bless, you're going to fix a lot of people. But sometimes there's just that lingering little thing, and it's a lot better. This is what I get a lot of times with these rib things. It's a lot better. The stretches help, but then kind of starts to come back. It's not all the way there. Am I not stretching enough? This is where I start to think more the position, the bony anatomy, the structural anatomy starts to matter more to me. Is that kind of where your brain is going?
yeah. So there's two things with this, which is, I mean, this is one scenario where I think we can call it adjusting or mobilizing or whatever, is actually highly helpful. It's highly integrated
Right.
in the treatment process.
Mm-hmm.
In my experience. Now, can it make it worse or can it irritate the occasional one? Probably. And I think it's happened, but I think most of the time, this actually is a big part of it where the muscle work, like you said, it gets it halfway there, but it just doesn't seem to it doesn't resolve the issue. It's a little bit, it helps with the pain, I guess. But the other thing I was thinking of is the way I describe this maybe get us on the topic of, again, where it's coming from, what is
Yeah.
actually going on.
Right.
And there's not a lot of literature. There's no books written on this stuff. So, it's a bit anecdotal. It's a bit empirical in a sense, but I describe this. So when I see this problem, so let's say somebody does come in with neck pain and then I check their neck and, there's no cervical stuff. There's no discs. There's no TOS. Everything seems fine. The movement feels great. It doesn't even bother them to move their head, to be honest. Sometimes, especially passively, actively it might. But then let's say you narrow it down and it is coming from, we'll just call it a rib area in the thorax. So I tell patients there's usually two types of people that get this problem. And I don't talk about the ribs with them. I just start talking about a bicycle tire. But for most people that know the anatomy a little bit, if you just take the ribs from the posterior side and it's a big ring that comes around to the sternum and it kind of forms a circle, right? So we have, and I call this is the bicycle tire in my mind. The rim, you can think of the metal rim. So and I use the example of the spokes that go from the center of of the wheel to the edge of the rim. And that's okay. There's people who just did something. It's a bit traumatic. Maybe you twisted and sneezed really hard. Maybe you picked up something awkwardly. You did something, you fell, you twisted, you fell snowboarding, whatever. In my mind, a lot of these people are like, they're riding a bicycle. They hit a bump really hard. And let's say they break one of those spokes. Okay. But the rim is fine, actually. They just broke a spoke. Now, I know this doesn't really happen in cycling. It's just an analogy. But if you were to replace the spoke, everything's fine. the tire goes back to normal. There's no issues, and you move on. Let's say the other person hits the bump and they break the spoke, but they also twist the rim when that happens. So they have this torqued rim, and
Mm,
in that case, you can replace the spoke, but then you just keep riding the bicycle and like they just
mm,
keep breaking, and you don't know why.
mm,
Well, that's because the problem is the rim. You don't have a ring that's perfectly kind of sitting equal and is capable of being dynamic.
mm,
And if we go back to the rib cage, it's sitting in a good position and it is freely movable.
mm,
And so I say you want to be the first person, to be honest, because those are the ones where I work on that area a little bit. I might try to heat the area up or work on the knot or whatever you want to call it. And then
mm,
I treat that rib joint. I might put a like cold pack on it immediately after.
mm,
That's just something that I've noticed helps. Uh, and they think I'm some special genius. Like that 2 days go by and they feel amazing. I had a patient like
mm,
that this week. Um, if you're the other person, I say you're going to like me, but then you're going to go, it's coming back again.
mm,
So they might feel better. They might, maybe not. They might not feel any better, but they might feel better for a few days, and then it just starts to come back. Or they just have these
mm,
episodes all the time. They just, after a hard CrossFit workout, they get a really bad one, or
mm,
they get these 2 or 3 times a month, and they hurt. And sometimes they're really bad. Sometimes they're kind of mild. In my mind, now I'm thinking about the twisted rim scenario, and what that means is a rib cage that is kind of either restricted in some manner, it's compressed in some manner, the ribs are not able to freely move, there's a pull on one of them, there's too much, there's something going on,
mm,
and that's where that pain just recurrently happens. So it's a joint in my mind that's not happy, and the brain senses this. Just like if you were to dislocate your shoulder,
mm,
your pec and your lat and everything just hooks up like on fire, like it's fully electrocuted, right? Because it doesn't want you to, your brain doesn't want to lose your arm. Well, the reason why you get these knots right on top of it is because there's a sensory awareness of something's not right, and
mm,
it's painful. So you get a spasm and a contraction in that area to protect that area, which is a good thing. But if the threat is actually not that serious,
mm,
sometimes the protection can be part of the issue, at least part of
mm.
their symptoms, and the reason why they don't feel good.
No, that makes that I love that analogy, man. That makes a whole lot of sense. I think even building on that analogy, like there are people that have a very weak trim or tread, the outside rim of it, right? So like there are some people who have a thicker tread who may be able to endure a little bit more of that asymmetry or a broken twisted spoke or the bent rim a little bit longer than the
Mm.
average person. And then the more deconditioned a person might be, the more sedentary a lifestyle a person might live, that twisted rim or broken spoke could be very, very upsetting a sensory experience in their motor world, right? This kind of goes back to a little bit what we were talking about with bad posture. It's only bad posture when it's task oriented. Like your position is now not up to the task of what you're trying to do. Your bike rim is not ready to go downhill on a mount as a mountain bike. You can barely go down the street. I like, yeah.
No, I actually like that a lot. That's good, because that's what I see is I see the predisposition for this issue. There are
Mm,
common links. There are common things I see, whether it's a really forward head or really flat T-spine,
mm-hmm,
or maybe they have ribs up in the front. That's okay, but they can't, you can't push them down. They're not flexible. The ribs are almost, they're concrete in a way. Like there's no flexibility of their rib cage.
mm-hmm,
So like you were saying, their posture is fine. They've adapted to probably what they do every day for the
mm-hmm,
past however many years they've been alive,
mm-hmm,
and it's conducive to that issue, right? Sitting at the computer or whatever it is they do. But the moment that, yeah, they had to pick up a washing machine, that's kind of awkward, and you have to kind of twist and bend over to pick it up. They don't usually, and again, just for those out there trying to diagnose this issue, you usually don't feel it when it happens. It's
mm-hmm,
usually the next day. So I always ask people, what did you do the day before the pain came on, if they can remember it? So anyway, like that person who's got a very restricted rib cage, it's very stiff, it's fine because it doesn't do anything anyway.
right.
But the occasion where you put that demand on your body to break from the norm, is when these occur often,
Right.
so picking up that awkward washing machine, and then you wake up the next day and you just got this kind of achy knot in your shoulder blade, maybe even just kind of stiff to check for cars when you're driving into work
Hmm.
that day.
Hmm.
This is kind of where, so exactly, I like that idea of the tread being, what predisposes these issues, and it's, you can build resilience to handle more stress, like we've talked about, capacity, but
Hmm.
also I just see patterns that tend to yield this problem more.
For sure.
You see really good shoulder blades that sit on really good shaped ribs, and then when they're laying on their back, you can just kind of pump their ribs like it's an accordion.
Sure.
I don't, you're not going to probably worry too much about those people.
For
You
sure.
know what I mean? They're probably not going to get this issue. I'm probably more likely to think for them that something's going on in their neck or something like that.
Right. I think this goes back to tie in what we said in the very beginning of kind of reorienting the perspective on these cases like this, where seemingly disparate areas are involved in the painful cycle that, you know, sweat more during peacetime, bleed less during war. These people, this is what you're talking about, bending over in like the laundry room or something. Usually it happens in reverse. You start bleeding in war. You're like, oh my gosh, I'm in war right now.
I need
And
to
you're
get in
like,
shape.
yeah. Then you're like, okay, now I need to get in shape. Right.
Hmm.
Because in peacetime, you were not sweating to some degree. Like I literally had a guy who had kind of some of this rib pain stuff and it would go away. And it was pretty low. I think we were probably like 90% there. And he's like, how do I keep this thing away? And patients that start to ask questions like that, I know that I've got the treatment plan correct and they kind of understand I
Hmm.
want to give them the locus of control where they're not dependent on me. And I was like, awesome, dude. He was a deconditioned, lower 40s office worker, super nice guy. But I was like, dude, if you do 10 push-ups every day for the next 3 months, I'm telling you, you're not going to be feeling this. It's going to go away. You're going to get stronger. And he was just like, that makes 10 push-ups. I'm like, that's all you got to do. 10 push-ups. You skip a day, you do 20 the next day.
That's
And
just
he
to
was
maintain movement,
just to
or
maintain
break up
movement,
his pattern.
break up his pattern. He just sits at a desk. He's a lawyer. He's a dad. 10 push-ups, just a little extra capacity on. We've got the rim straightened out pretty well. If he doesn't do anything, I'll probably see him in 6 months, most likely.
Mhm.
But if he mixes in a couple, I gave him some other things too if he wanted to try them. But I was like, a minimum, set your minimum for the day. Did you just do 10 push-ups? I mean, for the level, once you start to see these patients from the deconditioned level to the very conditioned level, whether it's a bicycle tire of a Tour de France mountain cyclist versus like or a beach cruiser kind of bike, right? Like you can give them different things that you don't have to be magical. You know what I mean? You can add just a little capacity. And if you can get your patients to sweat a little bit during peacetime, then that
Mhm.
wartime never really seems like war. And I think that's kind of what you're getting at with these rib things. Um,
I
there was,
like the gentle approach though with him, because
mm,
in my experience, if you throw at them kind of a complicated or a highly demanding movement as
mhm,
their rehab, this will make their problem worse. So if you want to make sure that their rib pain hurts, tell them to stretch their shoulder a lot.
I
So,
understand.
pull your arm across your chest really hard,
Hmm.
things like that. That's twisting and turning. It's probably going to make it worse. So,
Hmm.
but let's say you calmed it down and he's kind of to where the patient was with you, and he's saying, how
Hmm.
do I keep this away? It's just like somebody who's never ran, who wants to run a marathon, right? You just start them easy. If you send them on a 20 miler, they're just going to hurt and be done. So if you say, well, I want you to do these, I want you to hang a kettlebell from your waist on a belt between two boxes and sit in a deep squat, and then do basically a windmill rotation up towards the sky in that position,
Right.
they're going to probably come in extreme pain again the next day,
For
because their
sure.
rib had no business. Their ribs don't know how to do that movement.
Hmm.
But just saying, hey, I need you to, hold a plank, and then over here I just do some bear crawls, nice and easy, or whatever it is,
Yeah.
push-ups. I mean,
Yeah.
any kind of movement that asks the body to be dynamic without too much stress. And of course, it depends on the patient and what their level of mobility is, etc. But yeah, it's a good point.
They don't all need a high level intervention with 3 surgeons in there at the time with a coordinated effort to reconstruct their body. Don't make it anymore. But I will say one of the things that changed for me, and we'll probably talk about this on another podcast, is the horizon of healing. Like, he's 90% there, right? And I have to give this guy a good idea of when to expect and what to expect. And I basically moved this guy's horizon for feeling really good out 3 to 4 months. And he's 90% there, so he feels good. But he's like, I kind of feel like this might take a while. And honestly, I bet if he is consistent with those push-ups, he feels way better in a month. You know what I mean? And maybe he looks into working out more consistently or whatever it is. I think pushing that out there, because a lot of patients are like, I got to get better now. This thing jumped up on me out of nowhere. And especially those injuries that came out of nowhere. They weren't traumatic like you're talking about. They didn't hit a rock. They didn't, there wasn't a dislocated shoulder. They just reached down, and then the next day they're like, I think I slept funny. I get a lot of these. I think I slept wrong. How do you sleep wrong? Well, either you sleep or you don't. What do you mean you slept wrong? It just, like, linguistically doesn't, but I get it. What they're saying is they woke up in pain, which is your situation where they hurt themselves. They did something weird yesterday. They bent the rim, and now they're finally like, this bike ain't going straight anymore. That's what I think definitely happened with patients like that. So when you see some of these things, I don't really know what happened. Patients also assume that if the pain popped up real quick, that, by the way, can go away really quickly. And sometimes that's not always the case, because sometimes that rim has been subtly bent for the last year, and they really haven't done much because it's been a pandemic and we're inside. So we haven't put a lot of stress on that bike, and it slowly just builds up. It just ticks and ticks and ticks and starts to hurt and hurt. And so they might assume that because it popped up quickly, that it has to go away quickly. But if you can give them an appropriate timeline for healing, a reasonable one, and honestly, if you can be comfortable enough to push it out a little bit, if you are comfortable enough in your skills to be like, look, I'm sure that given a good month, we can get you to 80%. A lot of times I find that I'll fix them way before. I don't say fix them. We get to a happier place a little bit quicker with that.
In my experience too, one of the things that'll give you an idea about this healing horizon would be, how many episodes have you had this before? Is this a recurring problem?
Yeah.
And if they say, yeah, I get these all the time, and get these after volleyball, or I get these after whatever, chances are you have a bit of a fight ahead of you, because it's a recurring issue, which means they're most likely the second person with the bent rim issue, which means there's a structural or a functional structural issue that you have to address, not just pop the rib and work on a muscle and they're going to be fine. Versus it doesn't mean it's always going to be an easy one, but the other person who says, no, I've never really had this before, I just did CrossFit for the first time 3 days ago, and ever since it's been killing me, there's a good chance that one can resolve quite quickly in my experience. So that might give you an idea of what to expect, which will give you some confidence when you are telling the person what to expect when you set their expectations. So just a little helpful thing.
We don't talk about it very much, but let's talk a little bit about like the intervention in terms of like, actually, I mean, would this be better if this was a YouTube video and you can come into my treatment room and watch me? Absolutely. But use your imaginations, you're smart kids. So like, one of the things I think about when I'm treating ribs, if I have, especially, and I think you said it earlier, we kind of glossed over it, but I think it's a real gem, the passive testing versus the active, right? Passive neck rotation versus active neck rotation. Same thing with weird elbows or shoulders. Like, you'll find active shoulder range of motion can suck. And if you can passively move them to certain places, it looks weird. I mean, this is another topic I wrote a little note on earlier about like false positives. Like, false positives are a trap. It's a weird kind of thing that it's a false positive. It hurts, but it doesn't. So there is that our orthopedic test is correct, but it doesn't matter somehow, but it definitely does matter, right? So I think the trick if more people understood the difference between what it means that passive range of motion is non-painful and active range of motion is painful, in the combinations therein. Let's see, passive range of motion is painful, then you've got a localized issue for sure. There is some neck, disc, soft tissue, whatever is going on there. If it's passive, you have to be a little bit weary. You may have to treat it to some degree. Like my friend Jonas says, he's like, I treat people's necks so that people think I treat people's necks, when really he talks about ribs quite a bit, right? But just for the patient's mental satisfaction, he doesn't want to have to explain all of it. Anyways, the passive versus the active. But when you go to actually figure out, okay, this is a rib issue. How do we start addressing these rib issues? You've cleared out some stuff. I think about what the ribs should naturally do. What are just the basic baseline capacities, characteristics of ribs? And one thing you can't ignore in terms of treating the ribs and what they do is that they are very much connected to breathing. Inhalation, exhalation. This is just called normal respiration. You also need to know, I think is very important, that you actually have two rib cages. You have a left rib cage and a right rib cage, and they are not the same. And if you've ever treated rib cages, then you know that the left and right are always different. Are they different because we can go into this? I think Bobby has a better spiel about why they're different. I just like to tell my patients, because people are left-handed and right-handed or right-handed, and those left and right, the things you do with your right hands put torque on the right rib cage. The thing you do with the left hand can put torque on the left rib cage. Now, they both can put torque on each, and then your hips can also play a role, but they're different. And I would actually like to, what's your reason for what? I know there are more. That's the easy way I explain it. Do you ever talk about why your left rib cage is different? I know that you think so, yes, or am I out there on this? Do you think left and right rib cage? Why is the left rib cage different from the right rib cage in your eyes, Bobby? That's what I want to know.
I don't necessarily look at it the same way you do.
Okay.
In that regard.
Yeah.
But I do know that they're almost always asymmetrical, whether it's left to right or even front to back.
Yeah, perfect.
So there's some, rarely do you have, an infrasternal angle that's equal on both sides, or you have the same flexibility in the same direction on both sides, or, whether it's lateral side bending or it's flexion, or, something is asymmetrical almost always. But I tend to try not to look at it from right or left. I just kind of just look at it for however it's sitting or what it's lacking in function.
How
so
do you generally
it's kind of the same thing. I just don't think right versus left as much.
Yeah.
But
yeah, how do you think about the rib cage? I think the front to back is a good one too, because some people just think about I think if anybody was listening, I might assume that we are only talking about the back of the ribs connected to the spine. If I was just listening, I'd be like, that's really what they're talking about, how the ribs connect in the spine. But we're also talking about the whole rim, if you want to think about Bobby's analogy, wrapping around the 24 ribs, which is also why there's a left and right, and how those are different from the backside to the front side, considering the whole three-dimensional bit of it rather than, say, right where it kind of hurts. So, for instance, I'll just go through a couple of the characteristics. Ribs on the left and or on the right, you can go through inhalation and exhalation, right? Or expansion and contraction, compression, decompression, right? Now, sometimes in the back, it won't inhale and exhale. Let's just say front to back. In the anterior side, you can inhale and exhale, and the back side may not move at all. Or you could do vice versa, where the front side is locked in and the back side opens up and closes. You can do the same thing laterally. Let's just break it down like that. That only one lateral side expands and contracts, and the left side doesn't expand and contract. One side expands a little bit more laterally than the opposite side. So in thinking in terms of expansion and contraction, or let's say inhalation and exhalation, sometimes you will find that the left side can get inhaled and stuck a little bit on inhalation. And sometimes you'll find that the right side can get stuck in inhalation and exhalation, more in that elevated position. So for instance, when Bobby's talking about side bending, let's say side bending on the right would mean that the left side is inhaled, specifically if you want to think about more laterally in a state of inhalation, and maybe the right side is stuck in a state of exhalation or side bending. So inhalation on the left would give you And if you were on exhalation on the right, that would give you right side bending. Correct? Is that what you're starting to
Yeah,
see?
yeah. And if you just think of like a balloon or a balloon that's currently being blown up,
Yeah.
and as it's expanding, as the balloon is expanding,
Mm-hmm.
you just think of where the pressure is, and the
Mm-hmm.
balloon is going to expand away from that area.
Mm-hmm.
So if your
That's a great example.
rhomboids and your posterior, everything is extremely tight, and your ribs are really far forward, you can think of like the beer belly, or even a pregnancy, like a pregnant
Mm-hmm.
woman. It's pulling everything forward, super tight back. Well, that's so tight in the back. The only way the balloon is going to expand is forward.
Mm-hmm.
It's going to go forward or up,
Mm-hmm.
right? Versus if you think of maybe who's somebody who's very hunched over, or somebody who's just working bent over or touching their toes, and they take a breath in. Well, they're either going to not be able to breathe if they're the first person, or they're going to be able to expand that balloon somewhat backwards.
Mm-hmm.
Or, you got somebody leaning to the right. Well, most likely as that balloon expands, it's going to go to the left.
Mm-hmm.
So you're going to see the ribs move up and away in that regard. So it's kind of, just easy to think of it from that perspective.
That's a
And if you
great
get
way.
people stuck in these positions, you're going to see, well, if they breathe, that balloon's going to always expand kind of in the same pattern over and over and over again.
For sure.
And then if you do that long enough, the other ones become unavailable to you. And that unavailability causes issues, because
Mm-hmm.
not necessarily for the funny kind of functional things we like to say, well, you couldn't change a light bulb on with this arm. It's more that things like this happen. Like you get a rib pain because you tried to access something that you really can't move well in, and
Right.
that causes an issue, right? Amongst a thousand of other things that this could cause problems with.
Sweat during peacetime. So like okay, it may not be a problem now that your right lateral side is not inhaling fully, and that your right lat is trapped up. You may be able to survive for a long time with that right lat locked on, and you stuck in right side bending, and your left side stuck in inhalation, until the demands, the task, the screwing in the light bulb, surpass you and that right lat being stuck on and always turned on, right? And
just
then your
make sure
body,
you get just make sure you get your pneumothorax on the right side, and
that's the
you'll be
best place to
okay.
get a pneumothorax. I've always said
Yeah.
that's the best place to get a okay, so the thing, we're getting a better picture about how the ribs move. So a lot of times, if you see an overextended person whose back is very tight, in relation to the ribs, whether it's a problem or not within treatment, it's good to know these things, that anterior side is probably filling up and that back side is not. The balloon is going forwards over and over,
Hmm.
right? So if I wanted to pick, let's say I wanted to start to fix a posterior, we've got a problem with posterior expansion. The muscles are tight secondarily. We know this because we've treated the muscles. We ask them to foam roll. They feel better momentarily, and then it kind of comes back. We see that structurally, positionally, those bones are in an extended place. Those ribs are rotated such that they are locked on the back and they are only lifting in the front. What would that? They were stuck in inhalation in the back?
Uh,
Right.
Inhalation in the front.
Inhalation in the front, the back is just stuck in exhalation.
Yeah.
We're not, and Bobby's actually made this analogy before, crocodile like breathing into our back. We're not crocodile breathing in our back. This is a good, if you do martial arts, they talk about breathing through the back, when you're in a chokehold, it helps you to breathe. That'll open up an airway as well, breathing through the back. So how do we get people to quote unquote breathe through their back? Let's just go anterior posterior. That seems like a very common one. What are your kind of interventions for that?
Yeah, and if the right and left are equal in this regard,
Yep.
to make it simple, well, there's
Yeah,
really
please.
two.
Let's start there.
There's actually just mainly two things that
Yeah.
you focus on, which would be reaching forward or pulling your rib cage back,
Mm-hmm.
and then basically counter nutation of the sacrum or the pelvis. So getting the pelvis to posterior tilt. Uh, Getting the pelvis to posterior tilt is going to basically flatten the lumbar curve, which is going to move the spine backwards and the lower ribs backwards. And then reaching or protracting is going to pull the shoulder blades out of the way. It's going to lengthen the muscles between the shoulder blades,
Mm-hmm.
and it's going to allow your T-spine to move backwards or to slightly flex
Mm-hmm.
out of that extended flatter position. So therefore, you have the ability to expand that balloon backwards. So you can reach, or you can
Is this
put
like a
your hands
push
on
up?
the
Are you talking
ground.
about a push up with a plus situation here, or
That's
a
one, sure.
plank plus serratus reach situation?
Yeah,
Okay.
yeah. Serratus reach, any of those things.
Okay.
Back, but you can reach away from yourself, keeping your back stuck to a wall, or you can have your hands on the ground and push your spine away from your hands.
Yeah.
Any of those things. I mean, you can force yourself into a reaching squat, all sorts of stuff. I mean,
Yeah.
but basically, any combination of those two things will probably help the most. So, I mean, because if you have a forward pelvis, it's actually quite hard. It's gonna be all upper body work. So if you get a little this is where your abs will help you, your hamstrings, serratus, all these things kind of will help you achieve posterior expansion. Yeah.
Absolutely. One of my favorite cues for posterior expansion that's been seeming to work pretty good lately. We'll do a little bit like of a wall squat, or if you think like an all fours cat cow, like, arching the back situation. If you can get patients to imagine that someone is trying to, like, say they're in the all fours position, right? And they're doing a cat where they're trying to elevate and round their back, right? But you get them to imagine that someone's like pulling like their ribs up towards their head, or like pulling the shirt off of their back basically, but grabbing the ribs and almost elevating the ribs up. So there's a difference between trying to round your back straight up or having your ribs being pulled up and forward towards your head.
The reciprocal, I say the same. It's funny you say that, because I use the same example but reciprocally. So I'll say
Mm.
the abs, their job, and I'll actually put my palm, or the kind of pisiform or wrist area,
Yeah.
close to their hip crease or something. I said,
Mhm.
because I have big hands, right? So my fingers will go up and touch their ribs. And I said the job of these abs are really to grab onto these ribs and to
Mm.
pull them down. And of course, there's some diagonal, to this, but in other words, the abs job is not only to pull the pelvis up in the front, but it's also to pull those ribs down,
Yeah.
which would be the counter to pulling the ribs up in the backside.
Yeah. I love
Yeah.
that. That's great. So like, do you give, I mean, I know it's kind of like a PNF pattern or something like that, like the pulling those right anterior ribs down to like the left ASIS, something like that situation, or pulling the left anterior ribs towards the right anterior hip, essentially.
Well, in this regard, I don't talk about that with patients, and I'm
Okay.
just
Yeah.
talking
Yeah. Yeah.
about basically just A to P here.
Okay.
Both in a symmetrical neutral position, the abs can pull the ribs down in the front as they're pulling the pelvis, you know, into counter nutation or
Got it.
backwards, right?
Got it.
So that gives you because that basically blocks the ability to expand the balloon forward.
Right.
So if you hold that tight enough and you have some capability of posterior expansion, well, then the balloon will start to move backwards, because
Mhm.
the opposition in the front is higher than the opposition in the back. It's just physics. It's just going to expand wherever the space is available, wherever the least restriction is.
For sure. And I mean, I think this goes back to our episode last week in terms of posture. Like, how does this posture happen, right? If we're looking and leaning forward, or we're literally shifting our center of gravity forward towards our phone or our computer or whatever it might be, then that is the direction that balloon is going to shift. And so that back area becomes tight, and we can't shift our center of gravity backwards. I do think you're right. I do think the best way is probably through the hips. Pulling it back. Reaching can be difficult, especially. There's one, I do this one exercise, since we're talking about interventions, there's a low row I do with some patients that I start it more with the sternum. So if you think about your sternum as kind of a pump handle, it should go like someone's lifting it up. It's like a running cue for people who do pose running. Imagine that there's a string, a kite tied to the bottom of your sternum and pulling you up and forward. So that you should be kind of lifting from there basically. But the converse is also true. If the bottom of that sternum goes up and forward, it also goes down and back. And so there's this exercise, a low row. We'll have patients kind of in a half squat, their butt on the wall. There's a band beneath their feet, and they're taking that band and they're pulling their hands towards their butt cheeks. They're not pulling straight up. They're rowing in line with their femurs basically.
Hmm.
And as they row back, they'll pull the bottom of the sternum up, And as they let their hands go down, the bottom of that sternum will go down.
Hmm.
So it is that reaching mechanism, but you just learn to tilt that sternum back and forth and back, get that pump handle mechanism nice and fluid. And the arms are kind of secondary to that. And once, man, if you can get that pump handle mechanism through the bottom of that sternum, and then you kind of think of moving a little higher through the sternum, if you can get some people to just loosen that area up, man.
Hmm.
I've talked about Tao and his moves from time to time. He's big on the transitional zone movements. So like he would just get people from the skull to the occiput, from the cervical spine to the thoracic spine. He's like, if I had to treat you and I only had 20 minutes, I would just treat each transitional zone, the bottom of the thoracic spine to the lumbar, lumbar to sacrum, et cetera, et cetera.
Mm-hmm.
And so he has 7 of them. But there's a really good one when the patient is lying on their belly. And you just kind of follow, let's say you're standing on their, let's say you're standing on the left side of the patient. You put your hands across their body. And you know how the ribs in the back, they go kind of down and out, right? They're going down towards the glutes. So you are almost going perpendicular to the ribs. You put your hand on their ribs, they breathe in, and as they breathe out, you follow the ribs perpendicular to where their line would be, kind of almost pushing towards the right shoulder, and those ribs will sink down. So there's kind of rotating one way. And it usually takes a couple breaths before you feel that you follow it with the exhale and hold it, breathe in, follow it down with the exhale. And you can get that transitional zone to loosen up pretty quickly. You do that left versus right, and you'll often find there's a big difference in getting the transitional zone to kind of move. The same thing goes with like the cervical to the thoracic section as well. Like Bill Hartman has a move that I think is too passive with it, but he almost like, if you think about like it's like almost a logging competition where he's like sawing a tree, but he takes his forehand and he just kind of shears almost the CT junction.
CT junction.
CT
Yeah.
junction, yeah, like left anterior towards the left or kind of anterior towards the right. And typically with this pattern that we were talking about, let's just say that was inflated, inhaled on the left and exhaled on the right. Usually that means that the bottom of the cervical spine, the left spine, needs to rotate forward. So if the left side was inhaled, then the left side of the neck needs to rotate to the right. And so he would take his hand kind of at the left CT junction, left upper trap, and he would kind of shove that the bottom of the left neck kind of anterior. And so it'd be kind of the same way. You can kind of feel if there is a tissue problem that the tissue will stop first. And so you have to kind of shove past the tissue a little bit until the tissue lets go. It may take a dozen times. It's pretty simple, to be quite honest. It's super easy. And that will get that left neck to translate forward. And if you can kind of find the difference between the left versus the right through a couple of these little zones, it's a quick way to make a big change in some of these areas pretty quickly in terms of the ribs. What would, I mean, if someone was to start thinking about looking towards the ribs, I think the first place that they should look would be the active versus passive test. I know you glossed over that because you kind of have that on autopilot. I think it's brilliant. I think it's super smart. I think more people need to consider it. Beyond that, if you were to have someone to start looking at if the ribs are a part of my patient's problem, outside of that active versus passive testing, and again, what I'm talking about is Bobby saying active neck cervical rotation causes pain, say in the rhomboids or upper trap or something like that, but passive range of motion, you turning their neck slowly, doesn't cause pain. I would say that there's a good chance that the ribs are a problem there. Beyond that, what would you tell people to start looking? What would they need to look for to kind of see if ribs might be something they should start addressing?
Well, there's a couple things there. I think it depends if we're talking about addressing ribs in general, like how we kind of finished this conversation, or more of that pinpoint pain inside in the upper T-spine.
Good point.
Because I mean, even for me, who I think about this problem a lot, I don't go straight to trying to fix their rib cage. I'll often just try a very focal approach. It's one of the times where I think it actually is quite effective. So, the other thing on that point is that the passive can also hurt these ribs too, only because that usually less, because when you actively rotate, it pulls on these neck muscles that then go down into the upper T-spine and attach, and they pull on, that rib joint or CV junction or whatever that's not happy, and it reproduces pain, and the function's just not there. But if you forcefully rotate somebody's head passively, it's still the upper thoracic spine still has to rotate, allow that rotation. And if it doesn't, that often again triggers the joints in that area.
True.
So it can still be there. But I mean, honestly, for the former, for that nagging shoulder blade pain that people come in all the time with, or they'll come in with neck and shoulder pain, and you kind of, my first thing I do is go to palpation, because, and that's usually not my first line of defense for most things, is palpation. But this one is, because, and the way I usually like to do it is putting them kind of on a narrow bench if you have one. If not, just get them off to the side of the pain so they can hang their arm down into passive protraction.
Mm.
If you can't do that, you can have them seated, and basically like you're going to get, like they give themselves a big hug. So their arm is all the way adducted across their body, but you hold it. So I'll usually reach around them from the back and grab their elbow and pull it across their body.
Mm-hmm.
And what that's doing is it's pushing the rib cage back on that side, and it's also getting the shoulder blade out of the way. So it's forcing the ribs slightly posterior, and then you can go along these costovertebral junctions poking, and you'll often find the location. And then just because that hurts doesn't mean you have it. Then I'll sometimes, of course, usually this is after or before I've checked the neck and make sure there's not other things going on. And, I do screens for, like I said, disc and these other things. But once I know that there's a focal pain point, the first visit, that's all I do is I treat that area, because all they really care about is pain most of the time. So, and then if they're the second version, if they're the twisted rim, well, then I already set them up. Today, I'm trying to take your pain away the best I can. Teach you what to do. Here's how to use the lacrosse ball at home. Use some ice if it helps. Blah blah blah. But be prepared to come back in to do some stuff where we actually address the rib cage, which is what you kind of got into in the second half of the conversation. But many times, honestly, we may want to go there, but you don't have to. Half of those patients will get better without any specific addressing of their functional rib cage. Now, will it last forever? Probably not. And as they get more patternized, they'll probably have more of these issues until they get so restricted that they probably won't have any of these issues. It's kind of that weird thing with discs, right? Our discs are good until we're at this prime age of damaged. And then we have all these disc herniations for 30 years. And then we kind of get a hard disc and it doesn't really herniate anymore. It's too degenerated, it's too desiccated, and now you don't have disc herniations anymore. It's kind of like, I feel like once you get so stiff, you're probably not going to get so many of these. It's kind of it's a dynamic loss issue. If that answers. So I would start with,
that's perfect.
Palpation, clear out, make sure it's not actually coming from the neck, make sure there's not actual shoulder issue or impingement or nerve issues or a TOS or any of that stuff. Then this should go to the top of your list immediately.
The only I was just thinking the only other test I like also to do in terms of the palpation, the arm across the body is an awesome one for sure. Carol Lewitt, Greenman, some of the other like DOs from Europe back in the day, they also like to do hand on the neck where your elbow goes straight up. So you're almost putting them into more extension on that side versus protraction. There's just another option to have it. Just a different kind of way to palpate. You can find some different stuff. And typically if you're going to go into extension, you'll also get to see how much extension they have. So they basically put their hand on the same side neck, essentially. So your right hand would go on your right neck, your right elbow's forward. And then you would take from across their body, you're lifting their elbow up as you're palpating through that, the same kind of way Bobby is. You're just putting their hand in a different position. It's a good little test, and sometimes it can uncover some stuff. Usually there's a little bit lower in the thoracic spine, whereas Bobby's can kind of show a little bit higher in the thoracic spine. They're both great. What was the other thing I was going to say? No, that was it. Oh, there was it. We've said it before though, in terms of, treating the hot spot and then possibly, I like your make sure we focus on that thing. We've said this before, but we are firefighters and arson detectives. Make sure you put out the fire first before you figure out who's throwing Molotov cocktails over the fence. You know what I mean? Let's put it out. But if the fire starts again, be like, all right, now we need to go next door and see what's going on. But yeah, put the fire out first before you start playing Sherlock Holmes for sure. Other than that, just make sure to sweat more during peace so you bleed less during war. Tune in next time. Tell a friend. Share us. We appreciate you. If you have any questions, comments, concerns, leave comments below. See y'all next week. Peace.